ago, and sorry. And now we have 200 people who signed up for this great webinar on endoscopic spine surgery. So we are really excited to celebrate that. And yeah, thanks everybody for joining and creating this group. This would not be possible without all of you joining from all over the world. So we are very excited.
And today is also a very special day because, as you may know, is the World Spine Day, a day to celebrate everything that we like about spine. And we couldn't be happier than celebrating it with a webinar with fantastic speakers from all over the world. And we are very excited. So without losing more time, I'm gonna hand it over to our friend Jan from Brazil, who will start presenting this fantastic webinar. So go on, Jan.
So I'm Jan Silva from Brazil, and I'm really honored to introduce Professor Mazda Farshad, a renowned expert in minimally invasive and endoscopic spine surgery. He's the professor and chair of orthopedic surgery and notably the youngest chief medical officer in the history of the University of Zurich. Professor Farshad has received numerous awards for his contributions to spine surgery and is a passionate advocate for endoscopic spine surgery. So let's hear from Dr. Farshad.
Thank you very much. It's a pleasure and honor to be here alongside my faculty colleagues. So I will just give you a presentation about how to approach the field of endoscopic spine surgery. And let's see if I can open up in a way that you can basically look at it. Do you see the presentation? Yes, okay. So, okay, you know, when you want to achieve the field
Doctor?
Yes?
We can see only both screens, so not the main screen.
Thank you. Give me 1 second to correct that. Now better?
Your
No?
PowerPoint. We can see the PowerPoint. It's okay to present in that way if you want.
Let me see how else I can show you that. I don't want to lose too much time, you know? Here. Okay. Now?
Yes.
Okay. So basically, planning to do endoscopy or implement endoscopy in your practice, first of all, you need to know that the reality might be more challenging than your plan and that you need mentors and training to get there. So basically, this is the overall learning curve in medical education. And you see that the learning curve goes alongside factors such as supervision, and then doing the procedures on your own once you're there, right? And if you look at the specific learning curve of endoscopy, there are several studies out there, of course, but there is always the apoptose of the curve, depending on what you're looking at, being it percentage of good results or surgical time. If you look, for example, for transforaminal discectomy, endoscopic discectomy, the values are somewhere around 30 to 70 cases until you get onto your asymptote of your curve. In reality, we have to basically extend this learning curve, and this is the way basically I think works good, and how we have implemented endoscopic spine surgery in our institution. So first, if you want to learn something, learn it with training, simulators, cadaver training, then visitorships, then you go to the stage of supervised surgery, where you're accompanied by an experienced endoscopic surgeon for simple cases. Then you can advance to complicated cases, and then you go to teaching. And this is basically true for one level of complexity. If you want to go to the next level of the complexity, you should start again here in the beginning. And then you might go directly to supervised surgery and skip the visitorships, because sometimes there are not so many possibilities depending on where you are. For that, you need to know what kind of complexity grade you're treating. But let's say that is something that I consider as a reasonable way to implement endoscopic spine surgery into your practice. First of all, identify the need in your setting, in your patient population. Then identify the administrative obstacles, being it hospital administration or reimbursement topics. Then get trained. I personally would start with a prone position, interlaminar endoscopic lumbar discectomy in a supervised way, and then go to unsupervised, same simple procedure on a low lumbar level, and then proceed through transforaminal. Me personally, and I know that that's debatable, but me personally, I would persist with the prone position of the patient, and then go on and increase complexity, but only if needed, and start again. Now, sometimes it can be overwhelming, and colleagues have done a great job to create a nomenclature of what spinal endoscopy is about. So you see here the lumbar spine, and that's the description of the techniques, basically, also for the thoracic and cervical spine. However, so far we didn't know which kind of complexity these procedures incorporate. And the topic of complexity is an important topic. We've done some work and published in 2018 in the Spine Journal a classification for complexity for spine surgery, where we basically validated these grades of complexity, category 1, 2, and 3, very simple, and validated that with, blood loss, surgical complication, length of stay, and so on, which correlated nicely. This we consider a valuable classification for general spinal surgery, so that you can basically know where you are at if you train people or if you lead a larger surgical team. For example, it wouldn't be a good idea to let junior surgeon perform an occipitocervical instrumentation if he has not already done category 1 and 2 surgeries. For endoscopy, such a classification was not present, and together with the founders of the Endospine Academy, we worked on such a classification. Here you see the basic summary of what kind of procedures can be done with endoscopic spine surgery. And of course, this is not totally comprehensive, but these are the most common. And other than the procedure itself, so other than the technique itself, there are anatomy-related and pathology-related factors when you do surgery. For example, in endoscopy, an easy access interlaminar L5-S1 is a factor. If you would try the same thing at L3-4, that's more difficult due to the anatomical reasons. There are some pathology-related factors. For example, is it a soft disc or is it a calcified disc? Is that a revision? Is a lot of scarring? Are there severe degenerative changes occluding your direct access, and so on and so on? So there are some anatomy and pathology related. What we've done is we've created a two-dimensional scoring system, and we've sent it out in the world and asked above 100 surgeons who are interested or who are endoscopic spine surgeons from several countries to basically put these categories. So again, the technique into the vertical axis 1, 2, 3, and put the morphological and anatomical and pathological complexity into one ABC. And this is what came out. It's a very, very simple classification, and simple is good because everything complicated will just not be used. This is for now the consensus. Of course, this needs to be validated in other countries, other settings, but also with clinical data, outcome data, complication data, and so on. So there will be a lot of work to do around this classification, but this is the proposed classification that we will hopefully publish soon. And you see how it works. For example, if you're doing an 1A procedure, that would be an interlaminar endoscopic lumbar discectomy, easy access for a soft disc herniation, that would be here. These are the procedures, because they might be complicated in the beginning, some visualization of the procedures, categorized by category 1, 2, 3. Again, comparison where you're with the ILD for a soft disc herniation versus, for example, a thoracic disc herniation, semi-calcified, which would need a transforaminal endoscopic thoracic discectomy, so a TETD, for a, let's say, more severe morphological complexity would be in the red area, which basically means you should not start with a 3B procedure, but rather start with a 1A procedure, then maybe proceed to a 1B or 2A procedure and work your way up if needed in your setting, right? So again, if needed. So this is one aspect. If you want to advance in endoscopic spine surgery, you need to know what you're treating, because endoscopic spine surgery is not endoscopic spine surgery. The techniques are differ in difficulty, in technical difficulty, and the pathologies also are different. And then the second thing is you need to know the complications. If you treat something surgically, you need to know, and you have to be able to treat the complications. And if you look, I have tried to summarize the most common complications for you. This is a interesting article summarizing 103 articles and pointing out the most common complications. And this is how they basically stratified their search. And we go now point by point. This is for cervical, posterior cervical endoscopy. The most common complication seems to be neuropathy. Whereas for thoracic surgery, the most common complication seems to be dural tear, paresthesia, and hematoma. So not so much myelopathy or neuropathy. For the endoscopic transforaminal decompression, lumbar, the most common complication seems to be dysesthesia and dural tear. For interlaminar, dural tear, dysesthesia, and hematoma. So by looking at these categories of complication, you see, and that's another review and consensus paper, that a lot of complications seem to be related somehow also to irrigation. That's why one of your first questions that you have when performing endoscopic spine surgery is how to put the pressure. By industry, the value of 40 is given as a good value, 40 millimeter mercury. But you know, there so far has not been a consensus on how high the pressure should be, 40, 60, 90, or whatever. And then sometimes you either occlude your working channel, or even when you put in instruments, the pressure can go up, right? And what we've done is serial of experimental, where we basically investigate this question. And the most important, let's say, outtake of that is if you have a dural tear, you have to be very careful with your pressures. I want to summarize that for you. So basically, this is the ICP, which is the intracranial pressure. That's the pressure you don't want to get to become high, certainly not higher than 15 millimeter mercury. And if you're performing endoscopy and you're having 40 millimeter mercury without occlusion, you're still okay. You're still below the value of 15 millimeter mercury in a case of dural tear. But if you go above it, you should be you might have increased intracranial pressure, which can lead to catastrophic neurological complications such as cranial hematomas, epilepsy, and so on and so on. So again, spinal endoscopy, this is a learning curve. Try to go in this direction. Think always, do you really need to go to the next level of complexity? Do you have this kind of patients? Do you want to go into this area or not? And know your complication. Great. Again, I try to sum up. This is basically the recipe of how I would suggest to implement that in your institution. And we've talked about the complexity grading, which might help you in organizing your mind around where you're at, where you're working at when you're doing endoscopic spine surgery. Thank you very much for your attention.
So very nice, awesome presentation, Dr. Farshad. We have a question from Brenda Virgil. Do you put always an instrument to measure the pressure? Do you use any instrument to measure the pressure always?
No. This is the results I show you. We did put in, that was a cadaver study with several pressure sensors implanted at different levels at the site of surgery, at thoracic, cervical, and intracranial level. And this is certainly something you don't do in real surgery. The only value on pressure you have is the value that the machine gives you, which has nothing to do with the reality. So if the machine tells you you have a pressure or you're applying a pressure of 40 millimeter mercury, that's not what you're applying. The pressure you're really applying depends largely on your design of the endoscope, on the backflow mechanisms of the irrigation. And there are several companies with several designs, and basically the physics principle of Bernoulli principle and Venturi effect, which defines how a created pressure gets to the point of the intraspinal pressure just by the length of your instruments and so on. So that has nothing to do with what happens in the body.
Just another question from Ramon Barbosa. What are your thoughts about using gravity instead of a pump?
So we've done also gravity irrigation and compared gravity and pump. Gravity is certainly a solution, and if you look at the surveys worldwide, around half of the people use gravity and half use pumps, with increasing amounts of pumps. But gravity is a very good solution, basically, and then you have to play with the height, right? So we compared 30 centimeters, 50 centimeters, and 1.3 meters above the patient level. And what I can say is that basically 1 meter and above, so around 1 meter, if you put the irrigation sac 1 meter above the patient level, that equals more or less of what the machine would call 40 millimeter mercury.
Great. I think we're almost at our time. We can go to our next topic. Jana will introduce Dr. Jan Gustav.
Okay, hi, my name is Jana Shadow. I'm a spine fellow with Professor Farshad, and I'm going to introduce someone who is and was deeply influenced by Professor Kim here, and his name is Jan Gustav. He completed various international endoscopic fellowships, and he will give us some insights on how to start an endoscopic career.
Good morning. Thank you so much for having me. My name is Jan Gustav. I'm an orthopedic spine surgeon from Brazil. I'm living currently in São Paulo. And I have done this 1-year fellowship in minimally invasive spine surgery in Korea last year under guidance Professor Jin Sung Kim And my focus on this fellowship was learning mainly uniporal and bipolar spine surgery. Well, my experience with endoscopic spine surgery was about in 2021 during my first year of fellowship in spine surgery. I was very impressed by the excellent results and the quick recovery of patients compared to tubular surgery. Then I searched for the best endoscopic spine surgeons here in Brazil, and I found these two guys, David Del Curto and Dr. Guilherme Meyer. And I just asked for myself, what did they have in common that made them the best surgeons, endoscopic surgeons here in Brazil? Well, both of them had completed a fellowship in endoscopic spine surgery in Korea about 10 years ago at the Wooridu Hospital. It was, I think, the most known hospital at the time. And after that, I just started searching for the best Korean endoscopic surgeons. And I finally found Professor Jin Sung Kim, that was a completely very great mentor. And he taught me many techniques as olive technique, that here in Brazil, we are more about doing A-leaf and T-leaf, but not that many olive. And also interlaminar approach for using uniporal and bipolar, and also paraspinal approaches. Well, after doing this fellowship with Professor Kim, I have visited other doctors, and Professor Kim, he guided me on this. I met this another doctor called Dr. Park Chon-un, that was a great surgeon in bipolar. And then after I came to Brazil, I started my career here in endoscopic spine surgery. And it was not that easy, because in Brazil, we didn't have that many instruments of bipolar surgery. If you bipolar surgery is very, very similar to micro surgery, because you have kind of the same instruments, but you also needed some specific instruments as working cannulas, and also the endoscopic cannulas. And our health system, we cannot use our own instruments. And mainly we have to hire like a company that they will provide the instruments. And this year was kind of very challenging, because me and another doctor from Korea, a Brazilian doctor that half Brazilian, half Korean, that came as well to Brazil, we started helping these companies to build these instrument boxes to perform the bipolar here. At this moment, we performed already 10 cases of bipolar, and we also are performing interlaminar and paraspinal approach for unipolar as well. Well, I think that if you are planning to start your career in your if you want to start endoscopic surgery, I would recommend you to first find a very good mentor. I mean, probably most of you here have already some contact with endoscopic surgery, but it's kind of different when you learn the technique in your country, and when you learn the technique just where it started, you know. So I think that this is the first step to learn this technique, and doing this surgery as the most perfect as you can do. And I think that you need as well, you need to start some easy cases for sure. I would recommend interlaminar approach. Alpha 5, I would say that for me, it was the easier approach for performing bipolar mainly. 5S1, I would say Hello? Oh. So,
Are you ready?
yeah, and basically you will need about 15 to 20 cases of bipolar to perform to be almost a master. I would not say a master, but to perform your surgery very well. But unipolar is much more harder. As professor said before, you would need about 30 to 15 cases to 50 cases to be a master unipolar. So I think that for young surgeons, maybe bipolar surgery would be a very great choice to perform your cases. You can do everything, basically. You can do interlaminar approach, you can do discectomy, you can do compression, you can also do far out syndromes and foraminal and extraforaminal pathologies, and also fusion. So I would recommend, as for sure, you to learn bipolar surgery. In Brazil, we only had unipolar for the past 15 years, but now we are starting the bipolar surgery here, and we are very excited about the results and about the needed of the endoscopic surgery here to develop more, because until now nobody were performing fusion, and I think that bipolar surgery can bring us this advantage over the unipolar approach. And but you can, in my personal opinion, I love performing unipolar as well, but I would separate unipolar surgery, unipolar technique for discectomy cases, and bipolar for fusion and decompression for sure. So yeah, this is some of my small experience. I just came out to Brazil about 12 months ago, so it's I'm very excited to the next steps. I have planning to going back to Korea to visit Professor Kim again and to learn again, because endoscopic surgery has a very steep learning curve. So it's very important to keep learning and keep visiting your masters to improve your technique and abilities.
Thank you very much for the insightful talk. So personal question would be like, if you could turn back time, would you start the same way? Would you even start earlier or maybe later? Can you give some information on that?
You mean starting about doing endoscopic surgery? Actually, I just finished my my fellowship in spine surgery about 2023. So last year actually. So I just went directly to Korea to learn endoscopic techniques. I think that this is like a differential for your career. If you wanna perform the best technique for your patient with minimum invasive muscle damage, less bleeding, less hospital staying, and also small incisions, that here in Brazil, people love this kind of things. They love to take care of their bodies and they don't want to have a big incision on their back. So this is the very important thing here. This was not so important in Korea about incisions. This is, people are more concerned about the pain, but in Brazil they also think about this kind of aesthetic stuff. But yeah.
Nice, thank you. Maybe one last question. Is it easier to perform an interlaminar or transforaminal approach for you?
For sure, interlaminar it's easier because you already know the anatomy. It's very similar to performing a tubular approach. So you already are very into this kind of anatomy. Transforaminal approach is much more harder. You have to watch many surgeries, and your first surgeries I would recommend to be with someone more experienced, because you can easily make a precision on the patient, a decision. So it's very dangerous for beginners. But I would say that paraspinal approach, there is a variation of transforaminal approach that you can also perform using a uniporal and bipolar approach. It's very nice. You make the incisions, there's like 1 centimeter to 2 centimeters lateral to the lateral border of pedicle. And I think that this is safer than the transformal approach. This is my personal opinion, right? So, yeah.
Thank you very much. I guess that aligns with the classification we just saw. So let's move on to the next.
Thanks a lot. Thanks for having me.
Great. So hello, everyone. My name is Rajesh Mishkov from Denmark, and I'm very happy to see that you're engaged with our speakers and enjoying the program, hopefully. So it is my pleasure to introduce the next stellar speaker of our endoscopy webinar, Professor Jin-Sung Kim, based in Seoul, who is a world-renowned expert and researcher in endoscopic spine surgery, minimally invasive and navigation-guided spine surgery, who also has significant roles in different societies, committees, and training programs, having a deep investment into the field. Professor Kim, the stage is yours.
Thank you. Thank you very much. Can you hear me okay?
Yes, we can.
Let me share my... Okay. So, hi, everybody. I'm very honored and I'm very happy to have you today. Thank you for having me. Actually, I have made the special preparation for today's the Aerospine News Club. You can see the Aerospine t-shirts. This is my special preparation. Okay, so I'm going to talk about the endoscopic decompression. So versus fusion. I'm going to narrow down the option indication of endoscopic decompression for digital spondylolisthesis. Before going further, I'm going to share this disclosure. I'm also supporting the Endospine Academy with the Professor Masta. Okay, so I have the big mission today. So that is, by endoscopy, I'm gonna save the stable digital spondy from the fusion, like the movie title, Saving Private Yan, right? So I'm gonna start with this case in that. I remember this lady patient is around 60 years old. She complained was the claudication left side over the 3 years. And she had a history of the microdiscectomy at the 5-6 level 9 years ago. Okay, just think of the solution, kind of recommendation from your side. Okay, this is contents day. I'm gonna talk about the natural history first, natural history of digital spondy and the current evidence and case vignette. That's the case and take-home message. Regarding the natural cause of digital spondy, please keep your eyes on the evidence. The majority of the patients in this paper enrolled 76% remained without neurorectification more than 10 years. It's the paper from Japan. So another great paper from Japan published, entitled the Miyama study is the research on the regular course over 15 years, followed having 200 paid participants. The author eventually found not only risk factor, but also preventive factor. Old age was one of the significant preventive factor. What about the meta-analysis on digital spondy? 10 studies were included. by the Roger Hartle and by the Professor Kokagawa, the author reached out to this conclusion. 70% of the patient with dysespondy might not need to get fused. That is the meta-analysis about the dysespondy. Okay, let us hear the voice of the legendary. Everybody knows Professor Harry Herkovich described his opinion of the natural solution for dysespondy. He highlighted mainstay of the surgical treatment is decompression for dysespondy. It's not the fusion. It was the already published almost 20 years ago, right? So the current president of NAS, Professor Kokagawa, published a great article, the NEJM the treatment solution based on the high-level evidence of dysespondy, right? This is the study, another the study design, study, famous Nordstrom trial, so published the NEJM as well. And last year, the authors of Nordstrom trial reached out to this conclusion through two secondary analysis, that is regarding the manner of the surgery for dysespondy. They cannot recommend the fusion surgery as the first choice of treatment. So what about 5-year midterm follow-up research? The conference alone was non-inferior to the conference with instrumentation. 5 years in patient with the dysespondy. This is the very we can trust this result, 5-year outcome. Okay. So what about other study in major journals? This is the paper Jane Spine 11 years ago. They figure out the residual features, motion at recesses, facet angle, which is facet tropism, and disc height. These all three risk factors. 75 chance of reoperation, right? Can he have better outcome with MIS decompression instead of conventional decompression for dysespondy? Please keep your eyes on this study by Roger Hartle's group. What he found through the MIS decompression was that the surgeons are probably able to get decreased reoperation rate. That's an important message. The Roger Hartle always followed the MIS, microscopic tubular approach over the top decompression, right? So what about the quality of evidence about endoscopy? Now we're gonna move to the evidence of endoscope. Surgery for lumbar stenosis. The first publication done by famous endoscopy surgeon Sebastian Ruiten and Martin Combe in 2009. That was the first randomized controlled trial, right? The first paper of bipolar endoscope was 2016 in Korea. So up to date, less than 100 papers. The number of related papers has increased rapidly, and now there are more than 200 papers. However, we just have the 6 papers of high-level evidence at the moment. So it is 2015, 9 years ago, when Dr. Ruiten in Germany published the first randomized controlled trial. Look at the journal name. It is not Spine Journal, but one of the pain journal, the pain physician. We can guess probably this was rejected by the mainstream journals. That is what I guess. Okay. Yeah, so it's written. And the last 2 papers is mine and my junior's paper. I'm going to introduce one of them. This is one of my recent study about the outcomes for randomized control between the 2 groups. Actually, it took more than 5 years to enroll 53 patients because a single surgeon. It's very technically difficult to enroll the patient in randomized control trial. Okay. Anyway, I got a result with this. clinical outcome were similar, but endoscope had better result related to the radiologic parameter. Right? The year before, Dr. Bid in Chulalongkorn University in Bangkok had another phenomenal academic achievement. This is the first randomized control trial between microscope tube and full endoscopic decompression for spinal surgeries. So what about the upcoming high-level evidence? Upcoming, near future, already. This is one of my government support research grant running from 2021. And this is a list of we have 4 randomized controlled trials for surgical treatment, lumbar disc prolapse and the lumbar stenosis. The first and second trial had bipolar, and third and fourth trial had full endoscopic for each pathology. It's a protocol already published and different the high level the journals. You can catch up with the published the protocol about 4 randomized control trial that many renowned hospitals in Korea have been involved. I believe we are already facing the time when the endoscope cases for treatment lumbar stenosis are ramping up. So let's back to the question for you guys with this case. What's your solution for this lady? So a couple weeks ago, I posted, "Dear spine surgeon, let me ask you for your suggestion for my patient who had been suffering from the left leg identity pain claudication and dysphagia. So please answer your choice for this lady at 59 years old." Okay. This is CT scan. You can see facet tropism. It's a little bit vertical oriented, but no obvious instability. But when you enter the spinal canal with the medial facet resection, bilateral side and too much resection, it definitely makes the iatrogenic spondylolisthesis. Sure, right? For sure. So this is the plan for you guys. You can see the visual. So this is a result from the LinkedIn. So most these surgeons, probably this is kind of the selection bias because of most following surgeon following me, they might prefer the MIS. That's why. So most of guy answer they prefer unipolar ULBD and the bipolar ULBD and transplant lateralized decompression, etc. Only the ACOP 2 and 3 and 4 surgeons, they follow the 1-level or 2-level fusion. But anyway, interesting. So I'm gonna share the post-op image and outcome. This is post-op embedded. So you can see the canal was decompressed well. In my my routine practice, I always follow the patient 1 year at the year of 1 year. I follow the MRI as well. This is the 1 year follow MRI. Nothing happened over time, 1 year. So what about the changes over time? 3 years follow. You can see the segmental lordosis and the risk degree of recesses and whole lumbar lordosis. Nothing changed over time, 3 years, right? So this is the degree of spondy, right? What about the facet joint? Look at this, the city 2.5 years after the surgery. So I actually preserved the complete facet capsule, facet joint itself, right? So I can say the case having the longest follow-up duration with MIS patient in the case of Digital spondy, this is a patient got the surgery 11 years ago. Look at the pre-op X-ray has low-grade spondy and synovial cyst with the stenosis. This is 10-year follow-up. At the year of the 10 years, so I suggest, what about checking the MRI again? Because the 10-year is something special here. You can celebrate your spine with still healthy, something like that. So this is MRI. and the X-ray, right? Nothing changed over time, the 10 years. I can say I've been working at a total number of the MIS decompression in it's more than 120 patients. I haven't calculated the detail, but my gut feeling, the revision rate, conversion rate to the fusion is pretty much less than the recurrence discontinuation, right? Because I assume the reoperation and the conversion rate to the fusion might be less than 5%. But anyway, so I'm gonna make it clear with the paper and evidence. So can endoscope get better outcome than the tubular surgery? Yes, I think so. Trust me. So this is a takeaway. Stable status bonding, low grade. So decompression supported by randomized controlled trial, sleep trial, and the fusion is not the first option for mild disease spondy. And the microscope improves outcome than the open decompression. And ultimately, we need to figure out which patient to decompression alone to manage the health cost. So outcome could be strengthened by the endoscope. This is my gut feeling and I'm gonna my lesson for you. But endoscope is one of the surgical tool, right? I believe endoscope on the spine is the best MI solution at the moment, but we should accept we cannot be a panacea for every single patient. So that's the final message for you guys. Thank you very much.
Wonderful. Thank you very much for this talk. I would like to ask patients, they can present with various degrees of degenerative changes in the spine needing surgery. So in your opinion, where is it difficult to choose between doing endoscopy and doing minimally invasive approach?
That's good questions. Currently we have the MIS, different kind skill set MIS solution for spinal decompression without spondylosis. Most popular is microscope surgery, and the other endoscope, unipolar and bipolar over the top decompression are the currently big fashion among the young surgeons. But regarding the outcome, so currently I haven't found any obvious difference between the microscopic over-the-top decompression versus endoscopic over-the-top decompression. So last month, I and the other Korean surgeons, we have published the open decompression, bipolar decompression, unipolar decompression for the spinal. And there is a multi-center study published in this scientific report, is one of the good journal. What we found through this kind of the approach, there's obvious the difference between open decompression. Open means the classic midline approach, subtotal decompression, versus endoscope. But between the endo, the unipolar, bipolar, we cannot find any significant difference between the two groups, right? So I think that is the kind of depends on surgeon's preference and surgeon's the level of expertise. So I think you are advised to learn unipolar and bipolar for your patient, but eventually the final adoption for you guys is up to your clinical So the country have the different. Some of the underdeveloped and mid-developed countries is not easy to buy the expensive endo tower, right? So in that situation, you can start it endoscopic spine surgery bipolar first, something, right? That's my the current the opinion for that.
Okay, thank you. We have some questions in the main chat. So from F. Levendaras, he would like to ask, what about the approach if the dominant symptom is back pain in degenerative spondylolisthesis?
That's good question. I actually prepare the case Bennett can answer that question but I skip because of time constraint. So I have the case of the post-laminectomy uh, patient who treated the uh, non-surgical treatment. That is the endoscopic ablation of medial branch, right? So patient has obvious the stable two-level spondylolisthesis followed by by the bipolar decompression by the another surgeons. The the reason patient came up to my clinic is actual pain, not radiating pain, because bipolar decompression worked very well for relieving the pain and the claudication, but patient should complain was changed to actual pain from the claudication, right? So I found the patient just have the actual pain, but it seems to be stable. So yes, we can recommend two-level MIS fusion, but had a discussion with the family for the future treatment and something. Yeah, a lot of the discussion, and eventually, patient accepted the procedures, endoscopic ablation on medial branch. So once I denervate the medial branch, causing the actual pain, actual pain dramatically dropped down. It was very successful. It was not the single case experience. I have the sort of the many experiences. So before going further with the fusion, so you guys should recognize we have the option. We have the option. MIS decompression sometimes, MIS denervation of the medial branch, MIS the endoscopic ablation over the SI joint something. So that deserve to be considered for your patient, right?
Thank you.
I should have present that case. Okay.
Well, maybe there will be another occasion to do that. Surely. I have another question from Sompun. So, Dr. Kim, in your experience, do the patients have a stronger preference for undergoing endoscopic spine surgery compared to other types of open or minimal invasive surgery?
Yeah, yeah. So right now, most of the patient in my practice, they already recognize the kind of surgery, different type, open, micro, endo, even bipolar, unipolar. So mostly they recognize the surgical procedures. But in my real practice, I don't want to uh, stick to one specific procedures. When I explain the outcome uh, to patient, actually the endoscope currently gold standard in microscope surgery. Even though I'm a big fan of endoscope, I cannot say endoscope is kind of the gold standard, right? So gold standard, plan A is the microscope 2, the MI is the fusion and the compression. But we have this still the very nice acceptable the plan B option. So I always discuss it with patient kind of plan B, plan A. considering you remember the paper Myanmar study, they showed the preventing factor and risk factor of degenerative bone disease. If the patient have the old patient are age is all advanced age, and the male the gender and the vertical oriented facet joint something, I can recommend the component alone in patient, but I don't. I usually respect the patient opinion, but I should try to my best to explain the current standard of care, and that is why how I make a decision in my outpatient clinic. Okay.
All right. And we have another question from David, asking quite an interesting question, if we should still learn or train the tubular technique, or if we should use our energy and time on endoscopy instead, knowing that MES T-lifts are growing.
Yeah, thank you. Yes, you should learn the microscope surgery first. So before going forward with endoscope, that is the kind of the step-by-step learning.
Perfect. Thank you very much. And I think this is on our side concluded. If there are any others interested in asking questions or insights. Well, apparently not. So again, thank you very much, everyone, for being a part of this wonderful webinar. We enjoyed having the three speakers share their insights, and it was very enriching for us. So we hope to see you again at another occasion. Thank you.
Okay. Thank you very much. Great. Have a good day, everybody.
Much. If Dr. Farshad, Dr. Kim would want to add any other thing at the end, we would like to really thank you for your presentation, and also Dr. Ian Bustov. Hope having you in the next webinar.
Definitely, yes. Thank you so much for having me.
It's great collaboration and a great team. Ian and the guy from Asia, guy from Europe, truly international.
Thank you.
Very nice organization. Right,
Thank you very much, everybody.
Thank you. Thank you very much.
Thank you.
So have a good day, everyone.